Hello, and welcome to another webinar from Operationalizing Peer Support. My name is Shelley Shore, and I'm the Program Manager. In this webinar, we are hosting Rita Cronise to present on the National Practice Guidelines of Peer Specialists and Supervisors. Rita Cronise holds a distance faculty position with Rutgers University's Academy of Peer Services. She has lived experience of a major mental health diagnosis and is certified as an advanced level RAP facilitator, a peer specialist, and a peer specialist trainer in the VA. And she led the development of an advanced peer specialist training for the SAMHSA-funded Recovery to Practice program. In 2012, Rita coordinated the development of the National Practice Guidelines for the Peer Workforce through the National Association of Peer Supporters, N.A.P.S. Rita continues to serve on an N.A.P.S work group, developing guidance for the supervisors of peer specialists and other related peer workforce issues. She is a frequent lecturer on peer support values, practice, and supervision. I'm so excited to have Rita as a guest in the webinar, and I apologize for the first few minutes of the webinar not being recorded. Enjoy the webinar.
On the next slide, I'm going to show us a slide that has a number of different values. And what I'd really like you to do is pick one and only one that's the most important value to you. And after we do this, I would normally go into a breakout room, and if we had a little more time, because I usually have more time with this, we would normally have a conversation about our values, but we'll just have a little bit of a conversation in the chat regarding this. So let's take about 2 minutes and look through these different values and choose the one that is most important to you. Once you've got that one value, go ahead and put it in the chat, but don't hit enter until I say, because I want to do something called a waterfall chat, which is I love doing waterfall chats. So choose the one that is most important to you, and I'll count down from 5 to 1. When I get to 1, go ahead and put that one value in the chat. 5, 4, 3, 2, 1. These are great. I'm going to save the chat because I have a program that I can't do while I'm doing a presentation, but it's about word cloud. And it's really interesting when you put a word cloud together, you can see the one that is the most important to people and the ones that are less important. But I'm just kind of coming through here.
Rita, I can share a word cloud in the chat if someone wants to do that. I can save it for us.
Oh, okay.
Okay.
Terrific. So we may come back to that at the end, which would be really interesting. But the thing that I was going to debrief with, because we usually have a conversation about what's the most important, and then we have a couple of questions that we do. And one is to go around the group and share the value you picked and why, and then describe something that gets in the way of living up to this value. So what are the things that prevent us from being kind? What are the things that prevent us from being caring? What are the things that prevent us from being compassionate? Those things that get in the way and that are the barriers to being able to live our values more fully, those are things that are interesting to explore, because then we can say, oh, well, I'm just too rushed. I've got way too much on my plate. I'm overcommitted. And that prevents me from being as kind and as caring and as listening to people as I would like to be. And I can give you a really good example. 3 minutes before I came on to do this presentation, I had a phone call from a coworker, and I said, well, I'll call you back. He said, no, it's really important because my grandmother is probably going to die today. And I'm like, oh, I really need to talk to him. And so hearing the reason why and understanding that, oh, well, I've got to give this presentation, but you know what? This might be a little more important for me to do. So I took a little bit more time with him than I normally would have. But then I thought, why is it that I don't do that with everybody all the time? So as we think about things that get in the way, does anybody want to share? I mean, we can unmute and share, right, Shelley? Does anybody want to unmute and share for a second? I'm going to stop sharing for a moment and see if anybody has ideas about what get in the way of being able to fully live up to your values. Burnout, yeah. I think of being overworked, overcommitted, funding requirements, reporting, yeah. Trauma, absolutely, absolutely. Lack of resources. Getting flustered, yeah, it happens so easily. Yeah. Addictions, for sure. And a lack of knowledge, yeah, that certainly can be true. Having to choose between different values that are each important. That is true, a values conflict, a conflict of values. Having lack of trust. So those are all really, really important things that get in the way. And so, in a second, having a hard time seeing my screen here. So then we usually do a debrief. How many of you pick the same values and how many of you could relate to the things that get in the way of living up to our values? And I'm sure probably of those things that we mentioned, everybody has had that experience of things that get in the way of being able to live up to our values. So now I'm going to talk a little bit about lived experience and what it is that creates that sense of pureness. So I recently saw some research that I thought was very, very interesting because we have experience, and everybody has experience. But when we talk about lived experience, the researchers were saying that it isn't really lived experience in the context of the way that lived experience is usually talked about, at least in mental health, until after somebody has had a chance to reflect on the experience they've had, which I thought was a very interesting way of looking at it. And that's where lived experience offers a different kind of knowledge, a wisdom, if you will, than academic knowledge. So when it's based on common experience, that's what makes peer support real. So it's that common bond. And the mutual sharing is the common thread that helps make peer support a genuine source of help. A little bit of history, and many of you probably know this, really well, but the Centers for Medicare and Medicaid Services recognized peer support as an evidence-based practice back in 2007. That's when they issued the guidance that gave, that said you can have Medicaid billable services if you have a state-approved training, if you have care coordination, and if you have supervision by a competent mental health professional as defined by each state. Because each state has their own Medicaid plan, they have their own way of defining all of that. And I know that there's a big push right now. In fact, I'm going to be going to an expert panel next month on, certification of peer specialists. I'm of the mindset that really states should have the ability to determine what peer support looks like in each individual state, but there should be more commonality than there is right now. And this was all happening back in 2007 and in the years that came after that in 2007. Back in 2007, there were no practice standards for peer specialists at all. There was nothing that helped to unify or to give guidance on what it is that peer supporters should be doing. And at that time, the National Association of Peer Supporters was established in 2004. They had their first conference in 2007. Around 2007, they started doing member surveys. They wrote a situational analysis of the field. I was very close friends with Steve Harrington, who was the executive director and the founder of the National Association. And they were doing he was doing all of these different things to really try to understand what the workforce was. And the workforce was asking for practice guidelines. So we created a task force. We had about 20 people on the task force. A couple of us were more active than others, but what we did was we took a look across all of the states at what kind of guidance there was for peer supporters. And we looked at things like codes of ethics, handbooks, different kinds of guidelines that were offered. And quite frequently, when we got to the level of what was being told to peer supporters that were working in clinical settings was more about what they couldn't do. Thou shalt not do this with the people that you're supporting. You should not do this with the people that you're working with, as you know, in supervision. There was a lot of thou shalt not kind of language that went with the guidance for peer specialists back in that day. And on the task force, we took a look at everything, but the ones that were really saying what they couldn't do were not helpful in defining what they could do. You know, you can't define a profession by what you can't do. You have to understand what it is that they can do. And so we went to the literature and we found a couple of different sources of wisdom. One was the World Health Organization Quality Rights Toolkit, which was more about the human rights and how to make sure that people were having their rights respected and protected. One was the Trauma-Informed Guide to Peer Support, Guide to Women in the Trauma-Informed Guide that was written. And it was really, that one lent a lot of wisdom as far as helping people who have experienced extreme forms of trauma, how to support them. And the peer support that came out of that book was probably the closest to anything that we saw that was the most helpful for saying this is what peer supporters should do. We also went back to some of the literature when the consumer operated service programs were being established, and they had some guidance there. So we took pieces from all of that and came up with recommendations for this is what we think. We had 10 recommendations to start with. We took it to a meeting at SAMHSA where we met with the Substance Use Committee. They all agreed with what we had and they added 2 more, so it ended up being 12 recommendations. We got substance use buy-in. And then we did a national survey. We had 1,000, between the focus groups and the survey, we had about 1,000 peer specialists from across the country who looked at what we had done, and they gave us 98% agreement. It was 97% for the substance use community, 98% for the mental health peer support community, and it was 99% in the VA. And that kind of blew me away because I thought the VA is never going to go along with this. You know, it's too touchy-feely, it's too soft. But then we recognized that the reason the VA gravitated to it so strongly was because it was out of the trauma literature, the trauma-informed literature. So here are the values that came of that. Peer support is voluntary, which trips some people up because they think we're talking about, not paid. You're volunteering for services, but it really is about making sure that the people who are receiving services are doing it voluntarily, that we're supporting choice, that is hopeful and open-minded and empathetic, respectful, facilitates change.
Sorry, yeah. Rita, are you sharing your screen?
Yeah, I'm not?
I don't think so.
Oh, no. So I went through all of that.
I was able to see it.
She was.
I can see it.
Yeah. I can see it
right now.
Well, no, now it disappeared.
Yeah, but I could see it. I was watching.
Okay.
I could see it just fine too.
Okay.
I could too.
Okay. I'm sorry.
Oh, no worries. Okay, so now I just have to go back to.
You're doing great. My bad.
No worries. And there we go. Are we good? So voluntary, hopeful, open-minded, empathetic, respectful, facilitates change, honest and direct, mutual and reciprocal, equally shared power, and that's probably the closest, to peer-to-peer. The value that is most peer-to-peer is that equally shared power. I'm not over you, I'm not under you, I'm equal to you. Strength-focused, transparent, and person-driven. So these are what I like to call the Boy Scout mottos of the. Oh, now I'm not sharing my screen. Hang on. Now can you see it? Okay, good. So I call these sort of like the Boy Scout mottos, like brave, thrifty, true, you know, all of the kind of pithy little phrases that help you remind you of what the values of being a Boy Scout are. These are kind of those pithy little phrases that help you remember what the values of peer support are. But the actual guidelines, when they were written out, we have both a definition. In the instance of the very first one, peer support is voluntary. Recovery is a personal choice. The most basic value of peer support is that people freely choose to give or receive support. Being coerced, forced, or pressured is against the nature of genuine peer support. And the voluntary nature of peer support makes it easier to build trust and connections with one another. So that's kind of the definition around the core value. But even more so are the actual, what we call the competencies, the practice guidelines. So when we talk about voluntary, the practice is that you help people you support choice. Again, do not force or coerce, to respect the rights of those they support to choose or cease support services, have the right, the peer supporters themselves have the right to choose not to work with particular individuals if that individual's background is going to be triggering or going to be harmful to both of them, you know, so that it always seems to be the focus is on the person served, but the person who is the peer supporter also needs to be able to have a voice and choice in who they support and how. So in situations where the peer supporter would be harmed, could potentially harmed, or could be in a situation where their interactions with the individual would be based on a traumatic experience from the past, the peer supporter would refer the individual to other peer supporters or service providers to provide assistance with the individual's interests and desires. Peer supporters advocate for choice when they observe coercion in any mental health or substance use setting. So that's the first value. And what I'm going to do now, Shelley, can you tell me how many people we have? We have about 60.
We have 66, but that includes our captioner and both of us. So okay. I would say 63.
So 4 to 60. I think I need 20 rooms.
Mm-hmm.
Okay, so what I'm going to do in a moment is divide us into breakout rooms, and there should be, if I'm doing my math right, there should be about 4 people in each room. Let's see, 10 would be 6 in each room, 11 would be, actually, I think I need 10 rooms, 12 rooms. Anyway, we're going to all read the scenario, and then we're going to go in our breakout rooms in groups of 3 or 4 people. And we can either role play or we can discuss the scenario. It's really good when you have the opportunity to role play it, where one person is a peer specialist and the other person is the person in the scenario, and you have a little bit of time to talk through the scenario, to actually role play the scenario. At the end of the scenario, you discuss what went well, what strengths were demonstrated, and anything the peer specialist might have done differently based on those practice guidelines. And then we'll return to the large group and we'll share our observations. So we'll take about 10 minutes in these small breakout groups. And I think I'm going to do 12 breakout groups. But before we go, I want to read the one practice guideline that I just did was peer support is voluntary. Recovery is a personal choice. I'm going to put this in the chat so that everybody can read this practice guideline, which would be the one we'll focus on. Then I'll also put in the chat the scenario. So let me just do that really quickly first of all. I've got too many things open on my screen here. There's the chat. So I'm going to start by bringing in the core values themselves. And then the further explanation of this one core value that we've got on the screen. Just so you have that handy for your discussion. And the last thing I'm going to put in the chat is the scenario. We'll read through the scenario first, and then I'll divide us into the small groups. All right. So here's the scenario. Cindy is our person who is receiving services. For some reason, I can't move the video out of the way. There we go. Cindy is in an emergency room where Cindy's husband and adult children have told her she can't go home unless she agrees to undergo ECT. Now, this is both a substance use and a mental health setting. So I'm combining two things, but it could be either ECT or it could be MAT. So unless she agrees to undergo ECT and or MAT, as recommended by the treatment team. She has refused treatment because she has not been given any other options or any explanation of the possible risks and side effects of ECT or MAT. So the person who's playing the role as the peer specialist, you're a new peer specialist on the unit. You've been called to convince Cindy that ECT or MAT, whichever, is in her best interest. What would you do? So now I'm going to divide us into the breakout rooms. We'll have 10, 12. And ready, go. And if there's any questions, go ahead and ask. But you should be seeing the breakout room available to you right now. And we'll be about 10 minutes in the breakout room. Couple of questions just to debrief this breakout room exercise. So for those of you that took on the role of or discussed being the peer supporter, what was that like?
I'm Janie, and
Okay.
it's not our place. I mean, it's good for us to help them to find more information about whatever it is, maybe, and just be there for them and be an advocate for them, and help them get more information.
Mm-hmm. Yeah, that is our role. Anyone else?
Yeah, our group talked about that maybe there's a misunderstanding. I don't know if who's telling us to go in there and do convincing. Was it the supervisor? Is it just the expectation of the family that maybe there needs to be some education about what a peer's role is before even getting to the patient, client, or individual, and just letting them know we participate in a shared decision-making model here, and we want to present lots of info, pros and cons of all options, including no treatment, and maybe letting whomever is trying to funnel us in to do something specific that's not what we're there to do.
Yeah, excellent. Maybe one more. Anyone else have a reaction as from the role of the peer supporter?
Yeah, our group really talked a lot about making sure that we advocate for the patient, as far as like maybe, they gave her only, 2 options, right? Maybe advocating and seeing if there's other options that might possibly work for her that she can swallow, and maybe, advocating with her family and helping them have resources to help understand her addiction, and just making sure that she has all the knowledge and all the information needed so that she can see the pros and cons of each choice and help her to see the result of the decision that she does decide to make. But ultimately it's her decision to make.
Yeah, exactly. All right, so let's flip over to the person who was being supported. If you have any reaction to that, if you were playing that role or discussing it from that perspective?
Our group had some technical difficulties, but so we really talked a lot more as far as, what might Cindy really need to know more about as far as the two options and what she is saying, no, I do want to do, or what I don't want to do. And why would she be saying that? Just really kind of understanding what the missing pieces might be for her. If there's a part of it is just not knowing what she's getting herself into, because they're both pretty substantial programs to be agreeing to in either direction.
Yeah, absolutely. Anyone else?
Gabrielle in our group mentioned maybe she's had experience with those and they were really horrific experiences, and we need to provide another type of option because maybe those come packed with trauma for her and she's just completely uninterested in trying them.
Yeah, very well could be. So just, do you think in this situation it was approached from a recovery oriented perspective in any way? No. Do you think this actually happens in real life? Oh yeah. And I'll tell you the secret in case I don't get there with the limited amount of time that we have remaining, but this scenario was based on what happened to me when I was basically forced into ECT. I was told it was either ECT or I would live out the rest of my life in a psychiatric unit in a hospital. And, neither of those choices were good ones. But I think back on that time, and what might have made the difference was if a peer supporter who was working from the values of choice, working from the values of helping me to explore what were all the possible options I might be able to work with, might have made a really big difference back then to me. This is many years ago, but I think about that often, and that was why that particular scenario crept into my presentation. Okay. I'm going to share my screen again and talk just a little bit about what I like to call the clock and the compass, because these are real challenges that face peer specialists. And what is done in the behavioral health field is sometimes at cross purposes. Peer supporters are helping people to find their own way, the compass, while the rest of the system is focused on being the most efficient and effective, and that's the clock. And I use these metaphors. It's out of a book by Stephen Covey from many, many, many years ago called First Things First. And I just love this metaphor because to me, it describes the difference between the peer supporter working in a system where they're really efficient and they're really trying to do things by the clock. And it's not that those things are necessarily bad, but when that's all that people are getting, then sometimes we lose track of the things that are most important. So I'll just read this passage quickly. Our struggle to put first things first can be characterized by the contrast between two powerful tools that direct us, the clock and the compass. The clock represents our commitments, appointments, schedules, goals, activities, what we do with and how we manage our time. The compass represents our vision, our values, our principles, our mission, our conscience, our direction, and what we feel is important in how we lead our lives. The struggle comes when there's a gap between the clock and the compass, and what we do doesn't contribute to the most important things in our lives. For some of us, that pain is intense. We can't seem to walk our talk. We feel trapped and controlled by other people or situations. We're always responding to crises. We're frequently caught up in the thick of thin things, putting out fires and never really having time to do what we want to do that makes a difference. We feel as though our lives are being lived for us. And it goes on. it's a good passage and it's a great book if you have not read it or not read it in a while. But when I read that, it just really rang true for me about what the difference is between the clock and the compass, describes what the difference is between the peer supporters that are in the system and really trying to help people to find their way versus the system itself and the people that are being efficient and effective at trying to help people to just get better. So anyway. So developing the guidelines for supervisors. I often will talk about what is it that is the ideal supervisor, and we go into this session, talking about that. We have a whole timeline on what it was that N.A.P.S took the actual practice guidelines, which were issued in 2013. And then in 2018, we had seen so many examples of supervisors that just did not understand peer support or peer support values. And so we created a new column within the practice guidelines that was the role of the supervisor in helping peer supporters live up to their values. And so I often, within the example, will take the one really clear guideline that we took out of the World Health Organization. They have a quality rights toolkit. So this is about respecting and protecting people's rights. And this one is about peer supporters facilitate change. So peer supporters facilitate change because some of the worst human rights violations are experienced by people with psychiatric trauma or substance use challenges. There's a lot more to it. There's the way that the guideline is actually peer supporters educate and advocate. So they peer supporters find ways to call attention to injustice and help people to find out that the injustice that they're experiencing is something that they have a say in, and to be able to advocate for themselves. And then the peer supporters coach and inspire people to overcome their own injustice. But the part here that is really I want to call your attention to is the supervisor's role is to define and model advocacy for the peer supporters, including advocating for organizational changes, coaching peer specialists on how to respect the rights of individuals, building on lived experience. And there's actually much more to this particular guideline, but I use this for teaching purposes to say that the supervisor has a role in helping the peer specialist to advocate for, on behalf of people, with people, and through the system to change. So it's about facilitating change. So this is just a little bit about where you can find the practice guidelines. And we would normally go into another scenario, but we don't have time right now. It's just that we would now use this guideline number 6 about facilitating change and, helping people to respect their rights. And so this, we would then go into the same scenario. Oops. Only this time it would be the peer specialist talking to their supervisor, and what would the supervisor do to help the peer specialist through this same situation. So you would role play that. You would sort of look at the practice guideline that says protecting and respecting rights. What can the supervisor do as far as talking to the people that were insisting that the peer specialist, try to force Cindy basically to adhere to one or the other of the treatments. And then really it's a lot more in this case about what can the supervisor do to help peer specialists to live up to their own values and practices. And again, and just these are some key tips that came out of some research that we did at Rutgers on what peer specialists themselves said about supervision. And it came out that the relationship between the supervisor and supervisee is the most important. Joanne Forbes was the person who did her doctoral work on this. And what she found, when she interviewed like 30 different people who were peer specialists being supervised by non-peer supervisors, by and large, they liked their supervisors. Their supervisors were great people, but they still preferred to be able to gain experience from somebody who had been there and done that, is kind of the bottom line. So everybody benefits from listening, availability, goal setting, transparency, responsibility, and realism. And what we learned again was a preference for supervision by a more experienced peer, having more autonomy, having more role integration so the supervisor can help the role to be integrated within the system, having more trauma-informed supervision and building supports, respect and having a positive non-judgmental regard for the peer specialist and their role. And again, support for autonomous functioning was really a key, people being able to be more autonomous. And then here's just some ways of putting the guidelines into practice. Share the guidelines with employers and supervisors. Focus on putting one a week into practice. Using the guidelines in your supervision sessions. Sharing examples with your peers. Debriefing the challenges that you're facing by using the practice guidelines as a way of self-reflecting on what am I doing and how can we do it differently and how can the guidelines help us when we experience challenges. And now I'll leave a few minutes for questions.
Can we get this in email?
Yeah, absolutely.
I love this. Thank you so much. I so needed this.
Yeah, I'm sorry we didn't have the longer time, but you know, it's hard to crunch what I find is the role plays are just so powerful, and you know, you have a chance to really examine what are we doing here and how can we do it differently. Any other questions?
I have a quick question, and this is kind of open to everybody. So we're at the YWCA, we're like transitioning into some peer support models for support groups. And I'm just wondering, like, something that I've heard consistently come up is like sharing lived experience. How do y'all decide what is appropriate to share? Because I know that sometimes when we do share snippets of things, it can open up sort of a can of worms that you can't close again. And oftentimes clients are like really curious about our own stories. So like, how do you navigate what you share and don't share and what's helpful to the client?
I'll leave that to the group.
I feel, oh, go ahead.
I just wanted to say can of worms is an interesting term. Like, I think we get healing when we're vulnerable and we are able to share that. And I think it's not about not allowing them to share, but having a safe space and nice guidelines in that group so that they can heal. So I share parts of my story when I feel it's appropriate. I don't bleed my story, but I'm very specific about sharing. Like, you know, if I'm leading a group, which is one of my favorite things to do, I'll answer the question. And so I lead with a vulnerable place where people, you know, vulnerability leads to vulnerability, you know, Brene Brown would say. So I'm an advocate of, you know, specific and doing it, you know, honestly.
I have to agree. For me, you know, I feel like I'm really close with my with my clients. And we have a total different relationship. It's just amazing. And I think when the hardest time I've ever had with sharing my story is with a person that is not a client. It's a coworker. Is the only time I learned to keep my mouth shut at work now. So, but with clients, it's amazing. It just happens. I think for me, it just happens.
Yeah. And I love the share the message, not the mess. That was good.
Yeah, I think it's when I share, when I'm working with someone, I keep it very pertinent to what we're happen to be talking about, just so that we can get a you know, they can see that I've been there too, and it helps to understand, but I keep it basic. I don't get into like the nitty gritty details. I won't, like, you know, if they ask me, I will, but I kind of avoid that, but I keep it very pertinent, and I'm very careful as to not turn the session into about me. And I wanted to, you know, always go back to the focus on them.
Yeah, I think what you said is really important, Julia, because people relate when they know you're like them. So if you don't share anything, they just don't know that you're like them or that you've had similar experiences. So there are parts of the message that certainly belong. And I often will kind of let the other person lead what they're sharing and then try to share something that's comparable, but not necessarily all about me, but something that's all about them, that helps to make the connection and helps to relate to what they're going through. If that makes sense.
Yes, but I think it's a very, very good question, though, and there are so many answers, right? I think telling your story as a peer is a skill, and it changes with everyone that you're sitting with. You want to, I think the can of worm allegory maybe goes to the place of, you know, you don't want to traumatize someone sitting in front of you with details that maybe shouldn't be discussed at this point, at this time, with this person. It really depends on the person sitting with you and the relationship that you already have. I heard someone say, you know, sharing your story is like you have salt and pepper. It's like using pepper, not salt. Sometimes it just, you share what is very extremely relevant at the point. And I believe that Amanda Polly has her webinar in February with Abby Wellemeyer, and they're talking about sharing your story. And so that could be very relevant for some of the people sitting here if you're interested. And Amanda can put maybe the link in the chat, or you can find it if you email me. I can share the link with you all. So thank you for that question. It was very important one. We are on time. So Rita, if you want to add with a sentence, I want to thank you so much for being here. I'm going to share the recording of this with everyone that signed up for the webinar, and we'll add Rita's PowerPoint if she's willing.
Yeah. Thank
Rita,
you for the
want to say
invitation.
something?
Yeah, thank you for the invitation, Shelley, and thank you all for, you know, participating so fully in the conversation. I appreciate it.
We appreciate it, and I'll follow up with that email with also details on our next webinar. Thank you, everyone. Take care, please.
Bye-bye.
Rita, thank you so much for being here. Oh, she's gone.